Hi, I'm Sarah Holt, the Regional Pain Block Coordinator at VHC Health. This series of videos is meant to help you know how to take care of your patients best when you have a patient on an on-cue pump. The on-cue pump is used as a continuous catheter infusion of ropivacaine when patients have some sort of surgical or traumatic injury need. Our trauma program implemented these for our rib fracture patients where appropriate to help with their pain, and a lot of orthopedic surgeons use them as well for management of postoperative pain while the patient is both in the hospital and when they go home. This first video is just a general outline of the inpatient nurse's role for a patient with a catheter. When you receive the patient from the postoperative unit, you will notice that the patient has a catheter inserted. It's about the size of a thin piece of metal dental floss, and that's how we explain it to our patients. And it's connected to a set of tubing that you will then manage the pump that is connected to that. This pump is an elastomeric pump. It is a double layered pump, and it also has a dial for you and the patient to manage. While the patient is in the hospital, you will only manage the rate of this pump per orders from the physician. When the patient goes home, they can also dial the medication rate up and down to meet their pain needs. So highlights for care while the patient is in the hospital is that you must look at your provider orders on the MAR and in the active orders that will guide you to take the best care of the patient. When patients are on-cue pumps, we need to ensure that we are doing a nerve block and LDA assessment every 4 hours for these patients. The nerve block assessment can be found on both the work list and in flow sheets, and it goes over 5 key questions. The first question is to make sure that this clamp is open. As you can tell, this clamp connects to the tubing and ensures that the patient's line is either open or closed. And you simply need to ensure as you're assessing that that clamp remains open while the patient's on the infusion. And if for any reason during an emergency, you can easily close it as well. The next question pertains to screening the patient for symptoms of local anesthetic system toxicity, otherwise known as LAST. If you are a nurse taking care of a patient with an on-cue pump, you do need to have taken the training for LAST and HealthStream. And if for any reason you don't have that training to refer back to, please reach out to myself or your educator to find out more information. Local anesthetic system toxicity is always a possibility with a continuous local anesthetic infusion, and we need to ask our patients if they are experiencing any symptoms. The top 3 questions you can ask your patient are if they have a new ringing in their ears, if they have numbness around their mouth, and if they have a metallic taste in their mouth as if they'd swallowed a penny. You need to just document whether or not these symptoms are present and document that in either the work list or flow sheet. There are also other symptoms listed on there. So in Epic, as in many flow sheet rows and cells, you can tell if you don't know what questions to ask, Epic can prompt you with those certain assessments for your patient. And we've done that for this as well. So if you have any other questions about what other signs I'm looking for LAST, you can find those in Epic. The next question refers to the patient's limb safety. It's a yes or no question. So for some patients that have a block, an upper extremity block, you want to make sure they're in a sling. Due to the intensity of the nerve block, we want to make sure that their arm is protected in a sling because they're not going to be able to protect their arm themselves. If for any reasons it's not applicable, you could just state there's no limb safety in place, but you can make that decision as a nurse. The next 2 questions relate to motor and sensory assessments. The motor assessment is on a 0 to 5 scale, and you're just documenting how much ability the patient has to move in the affected extremity from the block. And then you're also looking at a sensory assessment. Sensory assessment is yes or no, is the patient feeling decreased sensation at the site of the block? And you can simply assess that by taking an alcohol swab and rubbing it on an unaffected extremity, asking the patient if they feel a cold and wet sensation, and then taking that alcohol swab and rubbing it on an extremity that is blocked, and you can determine if there's a sensory deficit. Though sensory deficits are quite normal with this, they do not have to be present for the patient to still have pain control. The next section of the nerve block assessment goes over the patient's vital signs, which in most units now will flow in automatically, but you can document those as well if needed manually. We also want to take into account the patient's pain score and pain location. Again, a nerve block is designed to target one area of the body, and so for any reason they're expressing pain in an unaffected extremity, we wouldn't want to put that in our nerve block assessment. So you would want to be able to assess the patient's pain level on whatever pain scale is appropriate for him or her, and then document the location. The last piece that we want to assess is the LDA insertion site itself and making sure that that dressing is clean, dry, and intact. I want to call out, though, specifically, some patients will have what's going to look like several different dressing sites, and that's because if the patient, for instance, had a shoulder surgery, their dressing would be likely somewhere in this region for the insertion point of the catheter. And oftentimes our anesthesia team will tape the catheter around the neck and place it on the other side. This is not the dressing we are looking at so much. We want to look at the insertion site because that is where we want to make sure we have clean, dry, and tract. We're not leaking from that dressing or need to reinforce. This one is important as well, as it is where the extension tubing is actually hooked up to the patient and where the medication would be hooked up. But we simply tape it to the opposite shoulder oftentimes to get out of the surgical field for the surgeon. The last components are making sure that you are not treating this type of pain control as the patient's only form of pain control. Keep in mind that the patient can absolutely take other pain medications as prescribed, and that is actually to be expected. Our goal with a local anesthetic continuous infusion like this is to decrease the amount of other medications are needed and not to eliminate them entirely. So those are the basics of how a nurse will be caring for the patient, giving direct bedside care. And a few of our other videos that we are accompanying this one with, we'll go over just sort of the general workflow, discharge teaching information, and more. Thank you for watching, and stay tuned for more.